What happens when you have anterior segment reconstructive surgery and the outcomes are not what you expected? What about trauma to the eye? In this episode of OCuTALK, ophthalmologist Keith Tokuhara explains strategies for helping patients with post-anterior segment surgery complications, tells us about the advancements in surgical technology, and how to address trauma to the eye. Hello and welcome to OCuTALK. Today we're going to be having a conversation with ophthalmologist Keith Tokuhara. Doctor, how are you doing today?
Great, and thank you for having me here today.
Well, we're very excited to start this conversation with you. Why don't you tell us a little bit about your background and your specialty?
Sure, I did my training at the University of Hawaii, where I did medical school's training there, and I found myself in residency at Loma Linda, working with Howard Gimble, and that's what really developed that passion for cataract surgery. Howard Gimble, if anyone that does cataract knows, one of the founders of modern cataract surgery, developing the capsulorhexis step that we all use today. After residency, I then worked for another year doing a fellowship in retina. I did medical retina for a year, and that's when I really dove into complexity of, retina patients that had cataracts or traumatic patients that needed cataract and retina surgery. And a lot of that developed the passion that I have today, working on more complex cataract cases. After my training, I worked at the county hospital for almost a decade, actually, and that's where I got exposed to probably the most trauma that anyone could ever have in a lifetime, and we would see that in 1 year. And the largest trauma center in the area, the second largest county in California. So we covered a huge area of trauma that would get airlifted from the high desert, Adelanto, Palm Springs. The whole area would be airlifted there. So after all that, I said, I'm going into private practice. And that's where I am today. For the past several years, I've been working here in Rancho Mirage, who focus mostly on cataract surgery and medical retina. And if you think about it, it's perfect because of my background in retina. A lot of patients don't just have cataract, they have other issues too. And so that same age group are the patients who develop macular degeneration, and it really works perfectly for the demographic and the place I am now.
Well, that all sounds really fascinating. Today, we were hoping you could talk to us about anterior segment reconstructive surgery. So, to get the conversation going, what exactly is that?
Well, first you have to define the term. Anterior segment, in my mind, is the lens, the iris, and everything in front of the retina, basically. And so when you talk about anterior segment reconstruction, it's implying that there's a defect there, usually traumatic, whether it's from a true accident, like a car accident or a bar fight or a gunshot or a knife injury. Sometimes it can be iatrogenic. It could be from surgical trauma, such as iris prolapse during a routine cataract. These things happen. And when we try to restore vision, the anterior segment is critical for that. It's the all the pathways that light has to get through to get to our retina. So when we look at that, that's what I mean by anterior segment reconstruction. It's looking at the iris, the lens, and everything in front of the retina that we rely on so heavily for our vision.
Cataract surgery is one of the most common surgeries. So, from your perspective, what are the most common complications that patients may face after cataract surgery?
Great question. And actually, patients ask me this all the time. As we prepare, they say, what do I have to face? Well, you have the dreaded complications that we just mentioned as a side, but they're just so rare, like infection. How often does that happen? Retinal detachment, uh, lens dislocation. I think ruptured capsule is, as a surgeon, that's the probably the complication that a lot of surgeons dread, because if that capsule ruptures during surgery, it means more it means more surgery. It means more risk of complications later down the road, like cystoid macular edema or lens dislocation. That capsule rupture rate, I think in some studies, is up to as high as 4% across the board, which is pretty high, I think. But when you look at patients from a general point of view, some people say, I had a complication, my cataract surgery went bad. And you look, it was a perfect surgery, a perfect lens, but it wasn't a bad surgery. They often have other eye problems. Maybe they've got macular disease that wasn't diagnosed. Maybe they have dry eye that's not managed. So when people say complication, I think it's perspective. As a surgeon, we think about really bad problems like iris prolapse, like capsule rupture. From a patient, though, in their mind, if they have macular disease and it wasn't told to them beforehand and they weren't counseled it beforehand, that in their mind is a complication. So commonly, that's why we try so hard beforehand to diagnose all this to avoid all those pitfalls. But it also means afterwards, we have to counsel them through any issues if there is a complication.
So now you've developed a program specifically for patients who had less than desirable outcomes from cataract surgery. Can you tell us a little bit about that and what motivated you to develop it?
This is really interesting. For a year, like I said, I was at the county hospital for several years and training residents. And you will come across some very interesting scenarios working with residents. It might be their first cataract operation, and here I am on the side walking them through it. You'll come across some interesting scenarios. And so for a long time, I got really good at recognizing a problem before they got into that bird's nest surgically. But also, if they were already in it, it was too late. I got really good at correcting them. And this went on for years at the county hospital. We ended up starting our own residency program for a few years. And we were recruiting our own residents, training our own residents to do cataract surgery. For a long time, this went on. And I thought once I went to private practice, this whole repair idea, this correcting other people's problems and disasters from cataract, I would be done with because I would have my own patients. I would be in the private practice world. That would be it. As it turned out, it doesn't matter whether you're a first-year resident or you've been in your career for 30 years, complications still happen. And I think all surgeons have to be comfortable with that. If a surgeon ever tells you there is a guarantee, it's incorrect. That means they either are lying or they haven't done enough surgery because everyone has faced complications in surgery. And the key is for surgeons to be comfortable with that and even a step above, being able to find it quickly, to rectify it quickly. Sometimes while you're there, you see it happen, you fix it right there, and patient would never know the difference. Or recognizing it quickly and getting them to a place where they can be corrected quickly. So their recovery is not delayed longer than it has to be. So I think that's where this all happened. So in private practice, I started to get patients coming in for second opinions and more patients for second opinions. And then they'll tell their friends, well, I had a problem. I went to Dr. Tokuhara, he fixed it. And this started to happen by word of mouth. And very quickly, I guess word spread here locally, I started to be the guy people go to when there was a problem. And I thought I moved away from it after I was out of the training programs, out of the teaching, and I started to do more and more repair. And that's where this concept came. It's very easy to do the easy cases, but it's so much of a joy to do something that maybe a patient was told nothing can be done. And I like the thrill of that. So we came up with this program and came up with an acronym, restore eye function, optical clarity using surgery. Because if you can do something to remedy the anterior segment, maybe to reposition the lens, maybe exchange it, maybe do something for the iris to give them some meaningful vision back, it is incredibly rewarding.
So now how is this program different from more conventional post-cataract approaches?
Well, typically what happens, and I've seen this so many times now, the patient will have surgery, and let's say there was iris prolapse or iris damage. Afterwards, they go through all these different, sometimes they're not even told. I mean, they're not even told that they have an iris defect. Surgery went fine. The lens is in good position, but they suffer from glare and they just think it's just part of a normal cataract. And years go by like this. And I've seen many people like this. And in fact, I had a resident from the hospital rotating internal medicine, he literally thought that the way you can tell someone was pseudophakic was by looking for the iris defect. In the past, I think if you go back 30 years, iris defects were the way surgery was done with the superior incision. But nowadays, you never should see that. If you see it, um, sometimes we can remedy that, especially if the patient has visual disability, especially if they've tried sunglasses, they tried the miotic agents, the pupil is defective. Um, just a suture or two can remedy that. So there's a lot that can be done, and you just have to explore and look at those options and think outside the box and not just say nothing can be done. That creativity, I think, is important when you look at reconstruction for a patient. Really think about what the patient's experiencing and try to come up with ideas that maybe aren't the norm for that. And give it a try. I mean, what do we got to lose? As a patient that's suffering with glare, we should at least try, or at least offer it as an option for them.
How do you determine if a patient is a good candidate for your vision program?
Well, there's several steps. We do a whole thorough review. I like to look at the operative reports. We have to do an assessment of their ocular surface. That's incredibly important. In fact, a lot of times people come thinking there's a problem with the surgery. It's not. It's a great lens. Surgery's fine. It's just they have dry eye. And then we go through the counseling of the eyelid cleansers, the one compress, and go through all that because that's sometimes all they need. They don't need surgery. In fact, I'm happy in those cases because we can tell them their surgeon did a wonderful job. The FDA approved lens is in there and it's multifocal. So you have to now restore the ocular surface. So sometimes it's a matter of looking at the ocular surface, the refraction, and that's all you're done. But if you've done all that, now you look deeper into the eye, you look at lens position, you look at the capsule structure. Is the capsule compromised or not? We look at the posterior capsule, is there haze? And then we look at the retina. So you have to go through our sequence of events, our sequence front to back to see if there's any trouble along the whole visual pathway that can be remedied. A lot of it's not even slit lamp. Some of it is some of the diagnostic tests like meibography, looking at the meibomian gland structure, or topography, looking at the corneal shape. A lot of this can definitely be looked into, looking deeper than just you don't have any anterior segment cell anymore. You're done with surgery. The pressure's good, but maybe there's more to it that we're not seeing with our naked eye.
So, what technologies do you use to help pinpoint these problems like iris damage or dislocated IOLs?
Well, the first is just looking. You got to do an exam. We do a refraction and exam. Vision pressure. This is when we do our test for the residents. Vision pressure dilate. Let's look at everything. And if you can't see anything obvious, like a big iris defect or a lens that's tilted on the haptic in the sulcus, you have to dig deeper. And that's when we pull in more advanced technology, corneal topography, ocular surface testing. We do a lot of that here. We do point of care testing, uh, for MMP9, tear osmolarity. We look for all the problems along the pathway where anything that light goes through for us to see, we have to test all of that from the cornea back to the retina. And we look at everything. And what if there is a problem in the retina? Maybe we couldn't see there was a minor epiretinal membrane because there was a cataract in the way. Now that the cataract's out, patient notices those symptoms. What if there's a lot of floaters in the way? There's treatment for that too. So you have to look at the entire visual pathway. First starts with the exam, and that's where it springboards into the other testing that you do.
So, what are the most successful surgical options for iris defects? How do you determine how to proceed?
This is a whole stepwise approach. Normally, patients won't even have symptoms, and that's what you hope for. Sometimes I tell patients, oh, hey, you came for a second opinion for your other eye, but did you know your first eye has a little defect on the iris? You probably had floppy iris. Then we go into that whole discussion about prostate medications. And they don't even know, they have no symptoms, and it's great. We just say, well, when we prepare for your other eye, we'll be ready for that too. But if they do have symptoms, there's most surgeons, and when we talk to other cataract surgeons across the country, they do this too. We look to miotic agents, some of the pharmacologic drops. We look to optical aids because there's really minimal risk in that. Can you control the symptoms non-surgically with glasses or sunglasses? Can you do it with a miotic agent? For small defects that all that fails, well, then you do another non-surgical option like a painted contact lens or specialty contacts. And then if all that still fails, you've exhausted everything, well, that's when we start to consider surgical options for iris repair. And you look through the past 20 years, there's been so many advancements in iris repair with the Seepster knots. We don't even have to do big incisions. It's a tiny little 1 millimeter to get in there, tie a suture on the iris, and sometimes one or two is all it takes to close a small defect. So it's been fascinating to see the evolution of this. I remember the first time learning this in training, and we all had our model eyes and passing, shoestrings through it to do it without making a big opening. And here we are today. These techniques still persist. And there's many different modifications of this through the years, and I know every surgeon that does this has their own kind of modification. That's a lot of fun. It's actually a really fun surgery once you kind of get your groove in and you've done several of them.
So, when it comes to the dislocation of IOLs, how do you determine if you're going to reposition it versus a full exchange?
This is excellent. And you have to evaluate the extent of the subluxation. Sometimes it's just a little tiny bit and it's stable. We don't see the pseudophacodenesis. It's mildly decentered, but stable. If it's decentered but stable, often we leave it alone. There really isn't the need to put someone like that through risk. Sometimes it's stable, but when they look, you see it oscillate and they have that oscillopsia symptom. And every time I had a patient recently, every time he looked to the left or right, he saw the whole world jiggle. And it really caused him nausea. He couldn't function. He couldn't even drive because he's checking his mirror and the world would oscillate. When you start to see maybe it's centered, but it's moving like that, then we consider fixation. And you can do it now with tiny, tiny incisions. We don't even need stitches sometimes with some of these newer techniques that we're doing. Sometimes we use maybe a tiny proline and we use a double flange technique to fixate it to either the iris or the sclera. But for the tiny oscillations that are very symptomatic, like someone like this I just mentioned, who can't even drive because of it, we think about fixation. And then you see if the lens is further dislocated, either posterior or to the side, like a pseudoexfoliation patient or a Marfan's patient or traumatic patient, then you start to think about bigger surgeries. One great clinical pearl that I always tell residents is you have to, when you look at a lens dislocation, you have to always put the patient supine and look at it again, because you can do all your exam. You can say, hey, it's centered, it's stable. I don't know why they're saying that. We'll dig deeper, put them flat. Sometimes you'll put them flat and you see the lens fall back. So it's not moving side to side, up and down diagonally, it's moving back and forward. And this is the patient, I've seen several like this. They'll be in bed, they can't read their book. I can't see at night. My cataract surgery was a failure. I wanted to be able to read without glasses. They sent me for a myopic target. I can do it when I'm on my couch, but when I go to bed, I can't. And you look into the lens, there's loose zonules, the lens is falling back. So you have to look at all angles. You have to look left, right, look where the haptics are, look where the capsule is, and supine exam. So that's how you decide. If it's really, really far back, and when we're talking it's close to the retina, well, I don't do retina surgery, even though I did do retina training. I leave it up to the vitreoretinal surgeons. If it's very far back, then I'll often coordinate with the retina surgeon to do and help with an exchange. I found that for the past few years, doing an exchange with a completely clear vitreous cavity all the way to the base, the complication rate is very minimal. If there's still vitreous there, it gets problematic with the vitreous tangling around the haptics or your lens, either when you remove the old one or when you put a new one in. So having a clean vitreous is critical to success with the full exchange. So going back to your question, how do you decide? You want to decide how much the lens is dislocated, whether it's wobbly disabled or just completely dislocated. And then you decide, can I save the old lens, which I prefer, you don't have to do any bigger incisions, or if you have to do an exchange, Well, then we coordinate to make sure there's a clear vitreous. Sometimes they already have a clear vitreous. They had a scleral buckle and a vitrectomy, and now their lens is dislocated after that. And then, I don't have to coordinate. They already have the retina vitreous clear, so we can just quickly do an exchange in those scenarios.
So you've worked with a lot of innovations, a lot of different procedures. Could you sort of explain to us the advancements of these techniques?
I have been thinking a lot about this topic, and in my life, I've seen it. I've seen just a huge change, but there still are doctors that are using interchamber lenses. Literally, even this week, this month, I see this happening, interchamber lenses. It basically means if there's a problem with the cataract, you take it out and you put a lens on top of the iris. And early on in my training, this was like the go-to. It would do a big incision, put the lens in, and then use a lot of stitches to close it up. And I remember as a medical student working with Dr. Kokami. I don't know if you will ever listen to this, but I worked with Dr. Kokami as a medical student. And I remember working late into the night. We must have had a 5-hour surgery because he was working on a new way to do a new lens without a big incision like that. And he would take the lens, place it in the eye, externalize the haptics through two sclerotomies because he's a retina surgeon, and then close it. So now we're not doing an interchamber lens. We did a posterior chamber lens, but it was through an externalization. The takeaway from me for that was, wait a minute, why do we have to do what was done before? Let's really be creative about this. And I think that alone, that concept, it opened the door to all these new possibilities. And then working with Gimbal in my residency, all these concepts about capsule, iris capture, lens capture, can we do reverse optic capture? These concepts really went into how do you take the natural anatomy and without having to do any new implant, use the natural anatomy to your advantage, to its best. That concept carried forward too. The third thing I would say is early in the early 2000s, Dr. Hoffman came up with this idea of Hoffman pockets. Because up until that point, whenever we did these lens exchanges or repositionings, we were doing 360-degree keratomies with a huge conjunctival cut down, and it was cautery on the scleral bed, and it was a painful red eye with stitches for 2 weeks. Well, when we learned about the Hoffman pocket, we weren't doing conjunctival cut downs anymore, and now it was an easier recovery for the patient. Now, it still was hard. I would have to do a cut down. It was a tedious surgery. We're still there late. But the biggest change, like I said earlier, is the Yamane. When the ophthalmology world was, our eyes were open to the idea of you don't need to do a cut down. You don't have to cut the conch. You don't have to cut the sclera and do a tunnel. You can just use a tiny little 30 gauge or even 27 gauge needle to make a tunnel. 27 gauge is really tiny, 30 even smaller. You can do a tunnel and pull the haptics through that tunnel to secure it. That just opened the whole door to new possibilities for surgery. So I've seen this in my career. It's been amazing, the excitement of these kind of stepping points. And as surgeons, as we find and think about creative ways to use the natural structure to maybe use what we have in a way that's better, maybe more physiologic, I think we'll be better and better as surgeons. And we rely on each other. I learn a lot watching other surgery videos. And I think about these days, sometimes when I do a Yamane technique now, I have flashbacks. Not that it was bad, but I remember driving home from that 5-hour long surgery with Dr. Kokame, and amazing to see that. But the techniques have really evolved. And I remember driving home to Kalihi, middle of the night. It was like 10 p.m. And I said, that was a hard, long surgery. And nowadays we do it, we can do a Yamane surgery. It's just a fraction of the time. And the patient recovery is so much easier. They're not red like it was just stitches and red. And it was hard for people back then. And it's so much better now for both the surgeon. We're not there till 10, 11 at night doing surgery for a 5-hour case. It's better on all aspects, both the surgeon experience, the staff, the nurses, the patient recoveries faster. And I have just and so thrilled that I've been able and privileged to see this in my life. It's just been an honor to see this evolution through the years.
Okay, so when it comes to traumatic anterior segment surgery, then how is it different from more traditional surgeries like cataract surgery?
I would say this. Traditional cataract, you know the steps. The surgical tech knows every step. The instruments are on your tray, the same order every time. One, two, three, four. All the steps is always the same. And they know when you're done with this step, you go to step two, three, four. It's actually, some people ask, isn't it boring? Like you're doing the same thing every time. Well, I find it exciting because I enjoy every moment of it. It's like a movie that you want to watch 20 times and you can't get enough. You just love watching it. I love every moment. When you do traumatic cases, though, it's not the same step. You never know what you'll need. You might do step one and then eight and then two and then four. You're going to be all over the place. It's a windy road. Some people don't like that. Just like in life, some people like to be on the 10 freeway and just put cruise control, press the button and go. And it's relaxing. You turn the music on, AC in your face. That is, some surgeons love that. I do too. But once in a while, I like to be on that windy road on the Rocky Mountains in the sports car, imagining that. You never know what the next turn will be. You never know if there's a rock or a deer in the road. You have to move out of the way and you have to be prepared. It's that thrill of excitement when you do a traumatic case. You never know. And I love that part of it, being reactive and knowing when to do things in those moments. It's a lot more fun. I do enjoy the challenge of that.
Okay, so when a patient shows up with serious ocular trauma, what's the most immediate threat to vision, to the ocular integrity? What are you looking for? What do we need to stabilize first?
Yes, and everyone who's seen this, I've done so many ruptured globes in my life, more than I want to even remember. Number one, you have to close the defect. If you have a flat tire and you're on the road, you can't go. And if you have a flat eye, if your eye is open and it's ruptured, huge risk of infection. That's number one. Huge risk of sympathetic ophthalmia. So you have to close the wound. That's priority note number one, close the injury. And typically when we see a massive trauma, nail gun to the eye or, a tile injury, you got to close the defect. That's priority number one. And if there is any piece of foreign body still in there, you got to get that out. So that's number one. Prevent infection, close the wound.
So, what would be the determining factors if you rush a patient directly to surgery versus trying to stabilize in different stages?
I think the only time you would delay closing a ruptured globe is if there was other injuries. If they had a pneumothorax, if they have a huge open abdomen with a horrible car accident, well, yeah, do those other things first. Make sure you secure the airway. If there's a neck injury, stop the internal bleeding after a massive trauma. That's the only time you delay the eye part of it. The eye will come second to, the liver rupture. Um, but you got to close the eye. I think there would be no other reason to not close the eye. Leaving it open for more than a day opens up a whole can of worms. I've taken care of people, um, amazing stories of people who maybe were afraid to go to the doctor. Maybe they were doing something illegal and they kind of sat at home for a week with a ruptured globe, drinking to take the pain away. And I've taken care of people a week after a horrible injury, and it's more challenging, but you still have to close the injury. You still have to close it. And that's priority number one, and hope they don't get an infection. So that's always the priority.
So, what procedures then are most successful for regaining useful sight when you're talking about some of these cases of serious trauma, especially delayed ones?
I think what matters is the nature of the injury, because what part of the eye is damaged can tell you how they're going to recover. Um, For instance, if it was a nail gun injury and the nail somehow misses all the vital structures. I had a patient that had a nail injury. It went through one side. So nail guns are just horrible. If you're not wearing eye protection, even if you are, it still somehow gets around. The nail gun hit the ground because he was just testing it. It hit the ground concrete. The nail ended up bending to a slight angle. As he looked down to test to make sure it was working, it was loaded. And this poor construction worker, the nail hit one side of the pars plana, missing the retina and missing the lens, going straight through and piercing through the other side of the pars plana. So somehow, because the nail bent as it hit the concrete, bounced up and ricocheted to get his eye, somehow it missed all the vital structures. It missed the cornea, it missed the iris, it missed the lens, it missed the retina. It just somehow got through everything. And it was a perfect nail piercing. So in that case, incredibly lucky. We removed the nail, closed the pars plana with the normal like sclerotomy type closure we would do for a normal vitrectomy. He did fine. So sometimes you can get incredibly lucky with a horrific injury. But even a smaller nail, if it goes to the wrong structure, if a smaller nail injury happens to hit the retina, or worse yet, gets straight and targets the optic nerve, then even if you have a perfect closure, even if all the bleeding is corrected, nerve damage and retina damage, we still to this day have no cure for. If there's cellular damage, that's neural tissue, that's it. We still, modern science, modern medicine, at least in Western medicine, we failed to find ways to restore optic nerve or retina damage. So I think that's where the worst injuries are the ones that somehow damage the cell structure of the nerve, the optic nerve, or the retina. Because we can repair corneas, we can repair lenses, we can do irises now, and not the retina. The retina we can get back in position, but the cells of the retina, the photoreceptors, we can't regenerate. We don't have stem cells to do that yet.
So then what advancements do you see on the horizon that might potentially facilitate traumatic ocular injuries?
On the horizon, I sometimes imagine a future world, and a big part of that's going to be AI. If you can have maybe real-time imaging, like we're doing now, we're doing real-time OCT imaging during surgery. Um, if you can have an AI assessment of that to help predict outcomes, maybe help guide some of the lens choices that we're using, I think intraoperatively, that'd be really nice to have. We already have Aura. Aura technology gives us intraoperative aberrometry. We can tell with a laser what the refractive power will be. But imagine having something with real-time imaging of the retina structure or the lens or the iris or the whole thing, and maybe have an AI interpretation of it to kind of help give us possible outcomes depending on what choices we have, to help guide a surgeon through it with maybe options, weighing the risk benefit of each option, maybe percentages of each.
Well, thank you very much for joining us today, Doctor. It's really been a pleasure.
Thank you for having me.